Hi, good afternoon, everyone. Jack Sample, Mayo Clinic, Rochester. Thank you for the opportunity to present, and thank you for staying around to the last session today. I'll be presenting our institution's experience with bariatric surgery in patients with chronic kidney disease. I have no relevant disclosures. So as this group knows, with the obesity epidemic, increasing prevalence of obesity annually. Importantly, with increasing prevalence of obesity, we see the increasing prevalence of obesity-related comorbidities, namely things like hypertension and diabetes, which are significant risk factors for the development of kidney disease. Additionally, there's numerous and growing evidence showing that obesity and excess body fat in itself is also an independent risk factor for the development of kidney disease. That being said, metabolic and bariatric surgery does have many perceived benefits in relationship to kidney disease. These being not totally limited to being renoprotective, decreasing the development and progression of kidney disease, and also being a potential bridge to kidney transplantation. That being said, we know there's benefits to bariatric surgery and being renoprotective, but kidney disease in itself, we know has increased risk of postoperative outcomes. So that kind of begs the question, what exactly is the safety of metabolic and bariatric surgery in this patient group? And do the benefits of bariatric surgery outweigh the risks of chronic kidney disease? So we aim to evaluate the feasibility, safety, and long-term outcomes of patients who underwent either laparoscopic sleeve gastrectomy or laparoscopic Roux-en-Y gastric bypass in patients with chronic kidney disease stage 2 through 5. And we wanted to pay attention to postoperative renal outcomes, postoperative patient outcomes and complications, and what's the importance of this intervention in this patient group, specifically with patients looking to get kidney transplant. So we conducted a retrospective review of adult patients who underwent laparoscopic sleeve or Roux-en-Y gastric bypass at a single large academic institution between 2008 and 2020. We screened a little over 3,000 patients, and 320 of those were identified to have chronic kidney disease stage 2 through 5. After exclusion criteria, we identified a total of 302 patients. There were 177 in the sleeve group and 125 in the bypass group. After patients were screened, we classified chronic kidney disease and their staging based on the KDIGO criteria, which is a well-accepted criteria. And for the sake of analysis, we just lumped together stages 3A and 3B into one group. We determined the preoperative kidney function closest to the primary bariatric surgery, and then looked at these time points of 3, 6, 12, 24, and 60 months postoperatively. Additionally, like we said, a large amount of these patients were being screened for candidacy to undergo kidney transplant, so we followed multidisciplinary notes from nephrology and other associated medical and surgical teams. And then other postoperative data parameters we looked at included bariatric outcomes, percent total body weight loss, BMI, and then postoperative complications classified into early, under 30 days, and late complications. Of the 302 patients identified, they were largely comparable on sex, BMI, and comorbidities. It is worth noting, though, that the patients who underwent sleeve gastrectomy were much more likely to be dialysis dependent, so they had much more advanced kidney disease on average than the Roux-en-Y gastric bypass cohort. And then again, stratifying the type of surgery they underwent based on CKD stage, you can see that actually for the stage 3 group, there was a significant preference to undergo laparoscopic bypass. But then for stages 4 and 5, kind of as expected with the perceived technical feasibility and shorter operative times, significant preference for sleeve gastrectomy. For weight loss outcomes, for all time periods, 6 months on to 5 years, the Roux-en-Y gastric bypass cohorts had significantly better weight loss outcomes compared to sleeve gastrectomy. And then looking at complications, this is a graph or a table showing early and late complications in the sleeve group versus the bypass group. For early complications, again, defined as less than 30 days, there was no significant difference in complications between the two groups. And this is despite the sleeve gastrectomy group on average having more advanced kidney disease. However, when we look at late complications, there was a significantly higher late complication rate in the bypass group compared to the sleeve, 8% versus 2%. And there was no difference when considering the CKD staging within each group in the complication rate. This is a little more granular data using the Clavien-Dendo classification for the early complications comparing sleeve versus Roux-en-Y. Again, there was no difference between the groups here, but for the late complications, we did see a higher complication rate in the bypass group. Worth mentioning, there was one grade 5 complication, which resulted in patient demise secondary to a marginal ulcer bleed. So the interesting part was looking at the postoperative renal function here. So these are figures showing the differences based on staging, CKD staging, preoperative and postoperative renal outcomes. So for the patients in the CKD stage 2 group, we actually saw the large majority of patients having stability, so they weren't progressing and advancing in their kidney disease. And this data is from 4.5 years of mean follow-up, 4.5 years. So the majority of the patients were not advancing disease. And then in the CKD stage 3 group, we actually saw a significant amount of patients, almost 50% of them, downgrade or improve to a lower stage of chronic kidney disease. And again, another large percentage of the CKD stage 3 group staying stable, so not advancing disease. This trend was similar in the stage 4, again with a smaller percentage, but a reasonable percentage of patients downstaging, and importantly, a large percentage of the CKD stage 4 group staying stable and not advancing in disease. And remarkably, in the CKD stage 5 group, again, a large majority of the patients in this study were being screened for candidacy for kidney transplant. So 59% of the patients who were preoperative CKD stage 5 actually eventually went on to successfully receive a kidney transplant. And I think it was about 20% of the total 302 patients eventually went on to receive kidney transplant. So some of the take-home points here when looking at patients who have concurrent obesity and chronic kidney disease, patients who have more advanced disease are more likely to undergo a sleeve gastrectomy. However, patients who do undergo the Roux-en-Y gastric bypass have superior weight loss outcomes, albeit higher late complication rate. So there's some important considerations here. It's kind of hard to have black and white conclusions from this because patients with obesity, especially with comorbidities such as chronic kidney disease, are so medically complex and the goals of care are different between them. Is this something that we're trying to get the transplant for? Is it just for weight loss? So this is really when it comes down to the multidisciplinary team discussion, talking with the transplant surgeon, talking with the patient and the nephrologist, and understanding the patient's goals. So in conclusion, we found that the sleeve gastrectomy was preferred for patients with more advanced kidney disease with a more favorable complication rate, but lower complication, but the Roux-en-Y having higher complications late, and that metabolic and bariatric surgery may improve kidney function and be a bridge to kidney transplantation in patients with concurrent obesity and CKD. Just want a special thanks to my team, Dr. Ganem, for being my research mentor. Happy to take any questions.